Good morning, folks. Thank you for joining us. People are still coming in, but just a logistical reminder, as this is a Zoom webinar, please use the Q&A button in your menu to submit any questions that you have. You can submit them throughout the talk, and then we will have a cute time to answer those questions at the end. Also, if you're in the most recent version of Zoom, you should have an option to turn on automatic closed captioning in your menu, if that is helpful to you. And without further ado, I'll turn it over to Allison Spensley, who's going to introduce our speaker.
Great. Thanks, Katie. Hi, good morning, good afternoon. I'm Allison Spensley. I'm a doctoral student in the School of Public Health, and I have the great privilege of having worked at the Center for Infectious Disease Research many years ago. So I'm very excited about today's presentation. So I want to introduce our speaker, Dr. Carolyn Bolton Moore. Dr. Bolton is a South African physician who has been living and working in Zambia since 2004. She has a keen interest in prevention of mother-to-child transmission, interventions, and adolescents. She has 15 years experience treating adults and children living with HIV in Africa. Presently, Dr. Moore is an associate professor in the Division of Infectious Diseases at the UAB School of Medicine and the Chief Medical Officer at the Center for Infectious Disease Research in Zambia, which we call CIDRS. She completed her master's in epidemiology through the London School of Hygiene and Tropical Medicine in 2011. And she is currently a PI on the NIH R01, focusing on adolescents, and the protocol co-chair for the IMPACT 2017, which is a study of long-acting antiretrovirals in adolescents. So with all of that, clearly she has a lot to share with us, and I'm very excited to hear what she's going to talk about today. So Dr. Bolton, I'm going to turn it over to you.
Great, thank you so much. And so good morning and good afternoon to those of you who joined us today. As Alison said, I'm Carolyn Bolton Moore. I'm an associate professor in the Department of Medicine and the Chief Medical Officer since 2000. Well, I've been at CIDRS since 2004, and I've been Chief Medical Officer for, I think, about since the last 10 years, I think. I'm not sure, but around there. And I'm based full-time in Zambia. Just to start off with, I was just explaining before everyone joined the call that this is really, it's not a purely scientific talk. I've tried to use it as an opportunity to share with you some of the specific challenges that we see with mental health and with adolescents and mental health in adolescents within resource-limited settings, particularly Zambia. And also, I've tried to include a little bit of the background of CIDRS and the work we do, so that number one, I hope you learn something and find it interesting. And number two, there may be potential areas of collaboration going forward. So please, if you have any questions, do jot them down, and we will have time at the end for a Q&A. Again, I have to say that my topic, identifying and addressing mental health disorders amongst adolescents in Lusaka, seemed like a good idea several months ago. As I got into it, I realized that the depth and breadth of this topic is really way too much to cover in 1 hour. So I've really focused on some of the key areas that I believe are important, and specifically included data, research and findings from work which either CIDRS or some of my CIDRS colleagues have been engaged in. So I have included a little bit of other data where it was necessary for contextualization and comparison, but this is mainly work done by CIDRS and myself. So we'll talk a little bit about setting the stage. We'll touch on the global mental health pandemic. We'll discuss mental health specifically in Zambia. I'll present some of the prior research, some of the current research. We'll work together maybe to look at some research gaps. some conclusions, and then finally a Q&A. So for those of you who don't know where it is, Zambia is a landlocked country in Southeast Africa. It is a population of just over 19 million people. The annual GDP is around $18.96 billion, and adolescents and young people aged 10 to 24 comprise 33% of the Zambian population, and 53.4% are less than 18 years of age. So CIDES, as Alison mentioned, is the Center for Infectious Disease Research in Zambia. It was established in 2002 as a collaboration between UAB, the University of Zambia, and the government of the Republic of Zambia. And it had a three-part mission: service, research, and implementation. And CIDES is renowned for conducting locally relevant within existing government structures and existing infrastructure. CIDES currently has around 1,000 employees with over 40 active programs and studies. And the work which CIDES is engaged in is pretty broad and includes some bench work and laboratory work. There's an active implementation science unit, a very active social SSRG group, and I'll present some of their qualitative findings a little bit later. We have the pediatric group, the reproductive, maternal, neonatal, and child health group, TB, HIV, health system strengthening and primary health care, strategic information, monitoring and evaluation and learning, and of course, mental health. So a broad array of research that's going on and interests. So for my talk today, I've used the definition of mental health as referring to cognitive, behavioral, and emotional well-being, all about how people think, how they feel, and they behave. And some people refer to mental health or mental well-being as being the absence of mental disorders. And I think when you're addressing a program or addressing a need such as mental health within the public health system, sometimes just settling for mental health being the absence of mental disorders may be appropriate. So just excluding and developing screening tools and systems to exclude mental disorders, I think that's the first step in the process. But I'd like to include and work towards mental health actually being something positive, where we have cognitive, behavioral, and emotional well-being. So I think it's all part of the journey. The WHO defines adolescents as those people between the ages of 10 and 19 years of age, and that definition is used quite routinely, but it can also be defined as a stage of development between childhood and adulthood. And I really like that definition because adolescence is really, it's a period, it's not a single period in time, it spans over a period of time, and it's a multiple staged event that takes a different amount of time for different people. And so I think we must remember that there are multiple stages of it, and it's a period of development and change. So why should we focus on mental health in adolescence? So as those of you who have personal experience may know, like your own adolescence at home, the period of adolescence can be quite challenging. And so in fact, historically, psychologists have actually viewed adolescence as being a sufficiently negative transition, so much so that the concept of mental health in adolescence would have previously been viewed as a paradox or actually a contradiction in terms. So adolescence was always viewed as a period of stress, disharmony, in which psychopathology, personal distress, behavioral dysfunction, etc., were considered the norm. Thankfully, however, with the influx of data over the last 50 years, adolescence has now been seen for what it actually is, a pivotal developmental stage offering vast opportunities for growth, development, and a time of consolidation and maturity. Adolescence is a necessary part of life, and predictable chronic mild stress associated with adolescence has actually been shown to increase resilience later on in adulthood. So adolescence is a time of vulnerability. Our health systems are not necessarily responding adequately. Many low-income countries lack mental health policies, and there's limited data gathering capacity to monitor country-level epidemiology and service outcomes and service at an individual level. And we see the end result is a failure to provide social services, this lack of a continuum of care, and universal barriers to access. So if we look at mental health in adolescents globally, mental health problems often begin to manifest around the age of 14 years, with 10 to 20% of children and adolescents actually experiencing mental health disorders. Up to 50% of all adult mental disorders actually have their onset in the period of adolescence. And mental health disorders are a leading cause of health disability in the 10 to 24 years old age group, with suicide being the third leading cause of death amongst adolescents. And determinants of mental health, as you are aware, I'm sure, do include not only individual attributes such as the ability to manage one's thoughts, to manage emotions, behaviors, interactions with others, but also social, cultural, economic, political, and environmental factors, such as national policies, social protection, living standards, working conditions, community support systems, and those things. So they all work together. It's generally accepted that mental health problems are unequally distributed across the population strata, defined specifically by your socioeconomic status. There's very little data of this, particularly in adolescents, and more so in rural or, Study was a study in Norway which assessed over 5,711 to 13-year-olds, and it showed consistently that poor family economy predicted for mental health problems, and the parental education level predicted more greatly for externalizing than internalizing disorders. So externalizing would be those like anger, aggression, acting out, and internalizing disorders would be those like anxiety, depression, self-doubt. So why Zambia, and why adolescents? Why are we looking at mental health in adolescents in Zambia? Because youth in Zambia are vulnerable. Our HIV prevalence is around 11.1% in the general population. And whilst it's only probably less than 1% in adolescents, we already know of 65,000 adolescents who are living with HIV. Predominantly females, 40,000, and 25,000 males. Scarily, only half of these are virally suppressed, and this is according to the DHS a few years ago. Zambia also has one of the highest rates of child marriage in Africa, and one of the highest rates of teen pregnancy, both sitting around 29%. And substance abuse is really high, and I'm going to show you some of our data pertaining specifically to substance abuse. Furthermore, with the large HIV epidemic, we have approximately 1.3 million OVCs in Zambia, that's orphans and vulnerable children. And Zambia's literacy rates stand at 55%, with illiteracy being much more pronounced in females than in males. Again, the DHS of 2018 showed that 21% of adolescent girls and young women, 15 to 19 years of age, have experienced physical violence, and 34% of those in the 20 to 24 age group. Lastly, COVID-19, as it has affected the rest of the world, has greatly affected Zambia, with our schools being closed for almost 6 months over 2020 and 2021. And the results have been, or the effects of that are still being analyzed and still being collected. But we know anecdotally that we've had increases in GBV, in gender-based violence, in intimate partner violence, increased use of drugs and alcohol, and also increased risk-taking behavior, particularly risky sexual behaviors. So the COVID pandemic has affected Zambia and made our adolescents more vulnerable. Data on suicide are really difficult to find. Anecdotally, we have a really high level of suicide amongst our adolescents, particularly adolescent boys. But when you actually look at the data, it's really hard to find these data. And the 2004 Zambia Global School-Based Health Survey estimated the prevalence of self-inflicted serious injury within the past 12 months. And 43% reported seriously injuring themselves, with 11% reported seriously injuring themselves on purpose. And the variables associated with the history of self-infliction of injury at that stage were worry, sadness, previous suicidal behavior, and a history of ever having been drunk or using marijuana. The only data I could find on the crude suicide, I could not find an age-adjusted rate for overall suicide, including adults and adolescents, for 2019 was 7.3. The only good news being that this was a 9.8% decline from the 2018 data. So I'm going to touch a little bit on what is the prior research around psychosocial distress, including depression and substance abuse, because these are really the two areas of mental health that we have been focusing on over the last few years. So in a study by Sizia and colleagues in 2015, in fact, the study wasn't in 2015, they used secondary data from the 2004 school survey, which I've just presented. They The psychosocial distress was detected in 15% of participants, slightly less in males and more in females. Age of less than 14 years of age, male gender, and parental support amongst males, and having close friends were protective factors. And risk factors for psychosocial distress included bullying, involvement in fights, alcohol consumption, not being physically active, and lack of parental support. And I bring these up because I think these are areas where going forward we can look at, perhaps looking at different interventions and different studies to try and improve and decrease the risk of psychosocial distress. Furthermore, Page and Hall reported that psychosocial distress was associated with having sex with two or more people amongst adolescents. So having one partner was protective, but having more than one partner increased stress. Adolescent substance abuse, use of alcohol, tobacco, or any other drugs was a risk factor for psychosocial distress. And again, I'm presenting these just as a lead-in to the substance abuse data, which I'll present shortly. So the Applied Mental Health Research Unit from Johns Hopkins University did a study a little while ago. It was a randomized controlled study looking at, it was a controlled trial of trauma-focused cognitive behavior therapy in Zambia to investigate the effectiveness in reducing trauma-related symptoms and impairment in critical functioning ability. And these results showed that TFCBT was highly effective at reducing trauma-related symptoms by a reduction of almost 80%, of a reduction of 82% compared to the average decrease of 21%. However, I'm not showing you these data to actually talk about the study themselves. What I want to do is to show you some of the baseline substance abuse data that they collected. So it was 610 OVC aged 13 to 17 years old were enrolled from some of the high density compounds within Lusaka. 307 were randomized to TFCBT, as I said, trauma-focused cognitive behavioral therapy, and 303 were randomized to just standard of care, which is psychosocial counseling. The main outcomes were HIV risk behaviors, primary outcome, risky sexual behaviors, and substance abuse, and secondary outcomes were mental health. Now, frighteningly, these were their data for their baseline data. So if you look at use in the past 3 months among the full sample, so the blue bars are use of drugs in the past 3 months, and the red bars are hazardous use using the assist scale. So you can see for alcohol around 23%, for inhalants around 16%, for marijuana use 14%, cocaine 11%. The study was done in 2011 to 2018, so these numbers are probably higher now. Methamphetamines 8%, sedatives 8%, hallucinogens 11%, injection drug use 4%, and other substance 14%. But of note is this circle in the corner that shows you that polysubstance abuse was around 56%. And again, if you look at the hazardous use, at half, more than half, almost 60% of those using alcohol were defined as having hazardous use, and then in the 70s, between 74 and 77% hazardous use for the other drugs. So it really shows a high level of baseline drug use amongst our adolescents. So the Zambia Global Health School Survey, which I presented earlier from 2004, found 42% of students that were 13 years and younger had their first drink of alcohol in grade 7. And I think that's quite young compared to the other norms and the rest of the world. So drinking and drinking early. Sorry, I just need to move this bar out the way. So the emerging burden of alcohol and substance abuse amongst adolescents in Lusaka, Zambia. So the same PI who allowed me very generously to use his data in the last slides from Dr. Jeremy Kane has a KO1 study, which is exploring alcohol and substance abuse patterns and perceptions of service use amongst HIV-affected adolescents in Zambia. As part of this, he's doing key informant interviews, and he's kindly allowed me to present some of these preliminary data from his key informant interviews. And so, Apologies, I just had a glitch there. So, so the common substances that have been consumed by adolescents from his preliminary data are marijuana, codeine, spirits called junta, heroin and cocaine, and commonly used substances by adolescents in Lusaka. And these are mainly due to the availability and affordability of these drugs. So I've included some of these quotes just so that you can get a feel of what the adolescents are saying in Lusaka. So this is from key informant member number 5. He says, so adolescent drug issues, and especially with codeine, has become prevalent, and it is really alarming. Sorry, I'm just struggling with my... so the kind of codeine they use usually starts with beer lovers and Mossi, which is our local beer, then gradually comes to go to the spirits. The cheap bottles of phonogram plastic glass bottles. So these are bottles of homemade brew. And then in what particular these are local spirits, really hardcore spirits, probably 60 to 70% of all, but there's major of that. So the reason is that they don't find any effect if they continue taking the high percentage of alcohol. So this is very much that, translated directly, but really what he's saying is that they start off with the local brews, which have a pretty low percentage of alcohol, and then end up taking these jigili-gilis, which are small little sachets of pure alcohol. And I have no idea what's in them, but I have tasted one before, and it really just does taste like pure alcohol. And so they're getting less and less effect from the beer, so they're moving to these stronger drugs. Sorry, I'm struggling to move it forward. And then key informant number 3 says, along the lines of rail, mostly along the line of rail, they take drugs like cocaine and heroin that has come on the market. But there are also these other recreational drugs. But basically, the main one would be marijuana, apart from alcohol. The prominent drug that is used for those along the line of railroad would be cocaine and heroin as the alternative drug. So again, we see these key informants, and these are all adolescents reporting these drugs. And Zambia, if you look at a map of Zambia and you draw a line sort of from the bottom to the top, that's the line of rail. So goods come in from South Africa and from the countries south of Zambia, and then go up to Tanzania and to the harbor at Dar es Salaam. So you see this straight line of road and rail, and that's where the predominant use of cocaine and heroin is occurring. And then the next key informant says that heroin is becoming more affordable, and it's unfortunate from my discussions with some of these youth, it's the suppliers that entice them to get started. The idea is to get them addicted or dependent on these drugs. The number has increased and become relatively more affordable. So it's not just Chibolya. Now, Chibolya has historically been the area where drug abuse has occurred, and they're saying it's not just Chibolya where they can access them. They now have distributors, even in the neighborhoods, even in the middle to upper class neighborhoods. They are now also being found. If one has access to 50 kwacha, which is around $3, then they're able to afford. So you can see that there's this very high awareness of drugs within our populations. And lastly, asked about the reasons for substance or alcohol abuse. You see unemployment, peer pressure, and this being socially acceptable in culture being reported. So the issue of unemployment, these young people are not employed. Some of them have finished college, but they're wondering where they can find jobs. And so at the end of the day, they get frustrated, and they may end up maybe drinking as a way of coping with their frustrations. This was key informant number 5. Key informant number 2 says, I think it's mainly peer pressure. They want to feel like a man. They want to grow fast. Basically, if one of these friends had done it, we introduce the other one into it, and it becomes like a norm. So again, coming through with this peer pressure and unemployment being an issue. And there may be a very few, key informant 2 says that there may be very few who have come from broken homes. The population is very small. Most of it is peer pressured and recreation induced. And lastly, from our key informant number 1, one important factor is the culture we seem to have as a country of cultural drinking, which seems to be generally accepted and maybe encouraged. So people easily associate with drinking as a norm or as a social activity. Just like wake up, eat, maybe there's also drinking. So I think that there's a cultural aspect. and perception of alcohol as something good or normal and acceptable. So again, unemployment, peer pressure, and socially acceptable. And these are, I've just highlighted the key themes that have come through, but I think it's very clear from this. And so the last question that they asked these adolescents was, do they understand the pathway to alcohol and substance abuse? And Keen Foreman once said, so what really started, it's like one of the friends who have started using it, and then we'll introduce this person. And the next thing we find that they've started missing some lectures. The family will find that they've withdrawn easily, or they disappear from home for long hours without telling the family. At sometimes initially, it's not so noticeable from the smell that comes from the mouth or the breath. So they're obviously referring to children smelling or adolescents smelling of alcohol. And key informant number 2, alcohol consumption, it goes in stages because they start engaging themselves in alcohol, it becomes habitual, they become addicted. Once they become addicted, it means that even their brain function, it actually becomes slowed. These are some of the things that actually affect them so much. And I think for me, it's been really interesting to see that. And I have a little bit more, some additional key informed study from Sciences Research Group that showed the same thing, that these adolescent alcohol and drugs are causing, and to the fact that their functioning becomes slow, but they continue using these drugs. And so they were also asked about the services available for treatment. And what came up clearly was that there's a lack of youth-friendly rehabilitation services. And the adolescents are aware of this. So key informant number 3 says, so we have a handful of mental health facilities in this country, the leading one being in the Chanama Health Hospital, which is a residential place and center. So yeah, it doesn't cater to children and adolescents. It only caters to the adult population. So yeah, it's difficult for us to accommodate children with, but yes, they have the facility to help with detox and rehabilitation. As you do that, we do assist with all age groups, including adolescents, but it isn't the outpatient level. So this is somebody who works at Chanama who says you can get admitted for detox and rehabilitation, but there's no outpatient support aimed at adolescents. And this is our national mental health resource. And key informant 2 says, although we have some free spaces for youth in the facilities, this is something that we need to strengthen. Adolescents are a group that are very difficult to access health services. And it is good that we have these free spaces for youth as an entry point where if anybody is engaged in such activities like alcohol and substance abuse or tobacco smoking, this could be a very good entry point. And what we need is to build capacity in those same youths that would be able to talk to their fellow youths concerning these issues. And that's from key informant number 2. So again, understanding that they need youth-friendly spaces. So bear with me, I have a few more transcripts that I want to read to you. And I feel like the reason I'm sharing them is that I believe that it really gives you insight into the thoughts and into the population in which we're working. So Young Voices, we collaborated with Young Voices and got funding to do some formative work in a study called Be in the Know Zambia. And this unfortunately had to change slightly with the onset of COVID. And so what we ended up doing was identifying sexual and reproductive health needs during COVID. And what was interesting is even though the focus wasn't on mental health, key mental health issues emerged, even though they were not specifically screened for. And so in the end, we conducted 52 in-depth interviews and then contacted them via telephonically. We also developed a Facebook and a WhatsApp page for providing resources and information for adolescents. And so from the key informant interviews, we had we focused on some adolescents who had children previously. And this girl, I think she was a 17-year-old girl. She reports she reached a point of depression during and after her second pregnancy because of her failed relationship. This caused her a lot of anxiety and affected her relationship with her mom, her sister, and her children. I don't know what happened, if it was a depression. I don't know if it was a depression, like I became loud, like I would answer anything, because it's like people around would not understand what I was going through. And they thought whenever I was just pretending. I remember what time it was even difficult to accept my second born because of the pain. And she said something we didn't get. So usually when I feel pain like that, I would get the baby and give it to my mother and to say, I cannot do this anymore because the pain was too much. So I think what we're seeing here is that that we have adolescents with specific needs, we have postpartum and pregnant women with specific needs, but really pregnant and postpartum adolescents fall right through the cracks, and there are no mechanisms of support for them. And I think this is what you're seeing here. And in fact, we're not even sure if this woman didn't actually have postpartum psychosis, given that she says that she became very loud and was no one understood what she was saying. And the sad thing is that she was never treated. She just worked through it and is now doing okay, but nobody ever diagnosed her, and she never received the support that she needed. And then my depression didn't take me well. I used to drink. I remember getting wasted drinking. Like every time on Friday, the only option was maybe if I drink, my life will be at least. I'll forget about the pressure, because the pressure was too much that I couldn't handle it myself. So again, she recognized that that's why she was drinking, but she continued to drink. And I think we had a lot of a strong theme of isolation and abandonment. And you see 1-year-old female, she's looking for a job. She feels alone. The reason being, I've had a lot of disappointments, even from my friends and family. Yep, relationships. So at the moment, I'm isolated for a while. And she had her first child at an early age and is currently a mother of 2. And along the line, I actually got pregnant. I'm a single mother. Apparently, I have 2 boys. I had the first one when I was 16. Actually, the first one wasn't an accident. I actually got pregnant by my uncle. After that, I met the father of my second child. Things were very fine and everything was okay. Then apparently the mother never liked me. And again, so here we see a woman who's just casually explaining that she had a child by her uncle. It wasn't an accident. I'm not sure what she means by that, but it was her uncle. And this has never been investigated. She's never received counseling or support. It's just a part of the world she lives in. And lastly, again, this drug abuse theme. 22-year-old male, he says, spends his time walking and smoking illegal substances. He says, I just walking and talking around and smoking weed. Well, I would actually really want to do away with stuff like drug abuse and alcohol. I know if I can make such a sacrifice, I can enjoy life better in future. I think if I stop, especially taking alcohol, I would have more money to myself and focus more on building my business. So again, has some insight into the problem, but very few resources to change things. So thank you for bearing with me as I've gone through all of those. I know they take a while, but I do believe that actually having an understanding and listening to the words that they use gives you some insight into the desperation and into the needs of these adolescents. And whilst it was only a few quotes, these themes, I really picked on themes that were coming through repeatedly within the focus group discussions and the key informant interviews. And so these themes are really predominant and coming out very strongly. And I just chose 1 or 2 quotes from each of the themes. There were other emerging themes that came out too. There seems to be a disconnect between parents and their adolescent children. And it seems from the data that we've looked at that adolescents actually want to engage with their parents. And it's really coming from the parents, this reticence and this hesitancy. Culturally, sexual education usually occurs prenuptially. And what I mean by that is that culturally, just prior to you getting married, the bride and groom are pulled aside and they are schooled or educated by their elders. So the girls are taken to their grandmothers and their aunts and they're taught about what is required and what they should do as part of their sexual education. And the men are pulled aside and given a similar briefing. And so this only occurs right before marriage. And so many of these children do not have or many of these adolescents do not have an opportunity to learn about sex prior to just before getting married. It came out clearly that young people don't have the language even to speak to each other or to elders about sex, having never been exposed and never been allowed or encouraged to talk about sex. And as such, sexual discussions are often unplanned. Their perceptions are often based on peers' ideas or peer pressure, and they may not get the true information that they're looking for. So following the information that the Be in the Know received, they actually put in a couple of relatively cheap measures to address peer pressure. And so they used Top Tips, which is an online, it's a website you can access. And this presents possible solutions for addressing common issues or challenges. So they were from the themes and the emerging issues that came out of the key informant interviews and the focus group discussions. They developed a website where they discussed things like dealing with conflict. I have a boyfriend my mother doesn't know about, my father doesn't like, things like that. So they presented some possible solutions for addressing common issues and challenges. They also have a series of dilemmas, which puts forward potential situations and allows adolescents to personalize them or to identify with these dilemmas. So another way of trying to help adolescents see the different choices that they have and make their healthy choices for themselves. At the moment, your only access to the website is through a one-time link to the website, and this is because it's being used for research purposes. But once that the research is completed, this will obviously be open to the general public. And this last link that they have allows you to choose a persona and then choose where you want to go. On a premise where somebody will call in and say, I have a friend who, and they're too scared to say it's them themselves. It allows you to take on the persona of anyone you want to, and then navigate different decisions and different situations through the website. And that's aimed at trying to help peers just negotiate adolescence and negotiate a lot of the common challenges we anticipate or we know that they're experiencing. And the last quote that I've kept in was one from a recently published article entitled, "They Say That I've Lost My Integrity by Breaking My Virginity." This was the experience of teen school-going mothers. And it showed scarily that alcohol is even being used amongst pregnant adolescents. And they reported using alcohol consumption to cope. Adolescent school-going mothers resorted to beer drinking due to being embarrassed, feeling self-pity, and having low self-esteem. I really didn't know what to do that time I discovered I was pregnant. All I wanted that time was Chibuku, which is our local beer. It has helped me up to now to remove stress. People can talk. This time I don't care whatever they say. It, being alcohol, has helped me. Without that, I would have drunk poison. And this is an 18-year-old participant in grade 10. So again, using alcohol to cope even during pregnancy. So I think, a lot of those quotes have given us insight into some of the challenges that our adolescents are facing. We're going to discuss a little bit now about the current research and the current interventions that are there looking at improving these. But really, if we want to think about mental health in the Zambian context, how do we improve it? We need effective interventions. We need them to be adapted to our local context. They need to be scalable. Ideally, you want them to be able to be done at a community level or at a peer-led level. They have to be cost effective, and they need to be easy to monitor, because how do we scale up these community-led mental health initiatives without being sure that we're able to monitor them and to monitor the quality? And most importantly, we need tools to assess the competencies of these providers to make sure that they're doing more good than harm. And that's really difficult when you talk about scaling up mental health initiatives. So the MySpace Mobile App is an exciting initiative that is being carried out at CIDES. It's with MacAIDS funding. And originally the MacAIDS group had given CIDES some funding to open up youth-friendly services at several of the clinics. However, because of the COVID-19 pandemic, this restricted access to these youth-friendly spaces. And so they went in a new direction, adolescent programming, and they attempted to develop a very holistic approach to providing support and services for adolescents. And this was based on the very heavy adolescent presence on social media, which increased substantially during the COVID pandemic. And so the process in developing the app was very interactive. So they did numerous consultations with adolescents, both physically and online. They designed and brainstormed the app features with a group of adolescents. And then they engaged a group called Bongo Hive, who are a media company, to assist with the look and feel of the app. But basically what the app does is it allows you to engage with counselors. You can choose your counselor. On the right, you can see There's a picture of one of the counselors talking. This woman, her specific counselor is Nalungwe. If she wanted to change her counselor, she could view all. On the right, she could choose her counselor. And then there's the opportunity to procure condoms. These prices are incorrect. To procure condoms, and then she can go through the different products and get some SRH commodities. So that app is live and running at the moment. When they asked participants or some of the adolescents what sexual reproductive services they wanted to be included in the app, HIV services came out strongly, as did family planning and mental health services right there in the gray bar. You can see gender-based violence in the yellow bar, drug and substance abuse less of a priority. Sexuality education, interestingly enough, was a really small bar. Skills training, also a small bar, and then prostate cancer, not much interest in. So this was the array that they were offered, and so we try to focus that on areas where they felt were important. So there was the content and gathering, then they uploaded the app. They partnered with the M-Pharma to ensure that these commodities were available. Right now, the commodities are limited to very specific SRH commodity, condoms, some PrEP, some family planning, but we're hoping to expand that. And then the creation of posters to the marketing app. And the reason I've included this is that it also has, so you have information on SRHR, GBV related information, and it allows for interactive discussion of various topics and for some support, mental health support and screening as needed, and then referral to appropriate services. They also have Q&A live sessions with experts, both videos and audio, and access to new articles around HIV and PrEP. So this is a really exciting app that I believe will be well utilized by the youth. It has access to job adverts, access to virtual trainings, as I said, access to counselors in real time and private chats. And they have a safety protocol that allows for, if anybody has suicidal ideation or expresses any suicidal thoughts, they're able to refer these urgently to pre-existing services that can intervene. And then purchase products like condoms, emergency contraception, as I mentioned. Right now, it is only working on Androids, but the aim is that it will be for all smartphone users. The target is 18 to 24-year-olds, and it obviously includes a privacy statement for the user protection and for CIDR's indemnity. So I'm not sure if these slides will be available later on, but I can share this link in the chat box. If you do want to access it and have a look, you'd be welcome to. So I have two more studies that I'd like to present to you before we close, but the first one is being, it's called Reaching 95, 95, 95 in Adolescents in Zambia Using All Our Skills. This is a collaboration between CIDR's and Grassroots Soccer, and the two PIs, myself and Dr. Liu, who's from UCSF, and it's an R01 through the NIMH. Skills is a GRS, Grassroots Soccer, is a community-based organization that uses soccer and football, whichever you prefer. I'm going to use the word soccer to educate and promote information and education around sexual and reproductive health, around gender-based violence, around just good mental health and good physical health. And it does have a component of empowerment and teaching resilience. So they use, it's 12 sessions, and these are done normally weekly at the school in small groups by trained counselors. And then at the end of those 12 weeks, they have a big soccer match where the allure is to come to the big soccer match, but at the same time, there are tents providing HIV counseling and testing, access to PrEP, access to family planning, and access to other services. During COVID, when we were unable to do this, we actually we used community-based distribution of commodities to try and overcome the fact that girls were unable to access the products at the events. So the primary outcome was the uptake of HIV testing, or is the uptake of HIV testing, and the secondary outcomes, the uptake of contraceptives. And so there's a panel survey of 1,380 girls across 46 schools, and included in this we have depression screening and process data. So this will allow us to better understand the incidence and prevalence of, because we do repeat surveys on depression amongst adolescent girls, and also allow us to refer them to appropriate services. I think I've mentioned this already. So who are we referring them to? We're referring them to a group called Strong Minds. Strong Minds is a community-based group therapy. If you look at their website online, you'll see that they have a mental health chatbot called Omani, whom you can interact with. They have videos and other support groups, but the primary base of their therapy is really group therapy. It's facilitated by one of their trained counselors, and it is aimed at trying to address very mild to moderate common anxiety and stress-related. However, the success is based entirely on anecdotal evidence at this stage, and there's no rigorous evidence to support the efficacy. And so that's one area where I believe we need to look more carefully. So lastly, what I want to mention is the common elements treatment approach. So CETA is an approach that was developed by the Applied Mental Health Research Group at Johns Hopkins University. It's based on evidence-based treatments for stress, depression, anxiety, substance abuse, trauma, etc. The model was specifically developed for low and middle income countries and relies on non-mental health providers and lay healthcare workers. It can be used to treat individuals with multiple disorders or problems, and it expands upon a traditional treatment approach that focuses on one specific disorder. So the common elements part of the name means that you can treat many different disorders with one treatment approach. The good thing about CETA is that's been proven through multiple rigorous trials in low resource settings to improve outcomes in depression, anxiety, substance abuse, and in trauma and trauma-related anxiety. And CETA can be provided to people in their own communities, which makes it a really wonderful approach for places like Zambia. So currently there are two activities going on with CETA. One is an R01, which is evaluating the implementation strategies to scale up transdiagnostic evidence-based mental health care in Zambia. So as I'm sure you're aware, train-the-trainer strategies are widely used to build capacity, despite there being few randomized controlled studies testing the effectiveness for mental health treatments. So this is really looking at different strategies of training providers to provide CETA. And the idea behind this is that a lot of the costs involved in scaling up something like CETA would be training and making sure that there were enough mental health experts to provide the training. And so CIDES has worked with the Johns Hopkins team to develop a fully tech-based CETA training, which is done online on tablets. It's facilitated by a local provider, by a local provider, and can be used for local providers. And then the clients that these providers see and the council receive either tech via WhatsApp or Zoom or in-person CETA. And so the outcomes are both provider knowledge and competencies, and really counseling outcomes, looking at how the clients themselves do under the care of these providers. The exciting thing about CETA is that PEPFAR has also adopted it as a near core intervention, which means PEPFAR funding can be used to provide and to scale up CETA in PEPFAR supported countries. This is being integrated into routine HIV care and treatment services within Zambia, and it's currently focused on those with poor adherence or those failing treatment. So it's really addressing mental health issues in order to improve adherence and to improve treatment outcomes. But the idea is that we'll scale it up across all departments and allow access to CETA for all individuals, regardless of whether or not they're HIV infected. So in closing, some of the protective factors we have for mental health. Protective factors associated with psychosocial distress, psychosocial, not distress, with psychosocial wellness include living with both parents and good parent-teen connectedness. As I mentioned earlier, having only one sex partner, and there's a repetition there, but fine. If you're living with both biological parents and a good parent-teen connectedness, we're related to better psychosocial health. And I think these are things we need to keep in mind as we look at interventions to try and improve mental health outcomes. So the research questions are, can we enhance and build on the protective factors that have been identified? Is there a way to improve family units, to improve parent and child interactions? And in fact, there are some certified trainings that we do and that we support that really teach parents how to interact with their children and how to interact with their adolescents. Then can the gains that we've gained or that we've achieved be sustained using peer-led models? So many of these models and many of the trainings that we do are overseen by the experts, by providers through NGOs and through other organizations, but can these be sustained using purely peer-led models? Our school-based initiatives and COVID and the restrictions given COVID and the effects thereof, and also there are restrictions on schools with regarding the sharing of SRH information and access to commodities through schools. Are there other differentiated service delivery models that can be used? So I don't know if you're aware, but we use community adherence groups. These are groups in the community to try and promote adherence amongst patients living with HIV who need support for adherence and retention in care. We've integrated hypertensive screening and cardiac disease treatments within some of these CAGs, but can we integrate mental health into these CAGs too? And then technology. If you're talking about adolescents, you have to talk about technology. How do we use it and how do we monitor it? So in conclusion, I'd like to say that mental health issues contribute significantly to morbidity and mortality in Zambian adolescents. The key issues that we need to address include alcohol and substance abuse, GBV, unemployment, and HIV infection. There's a need for simple, scalable interventions that identify, treat, and help us to maintain the well-being around mental and address mental health issues. We need community-based and peer-led models, preferably for the mild to moderate cases. And then, as has come up in all the other prior adolescent work, nothing for us without us. We can only do this work if we continue to listen to our adolescents and be led by what they want and what they need. I'd like to acknowledge my team, the CIDES team, the Johns Hopkins team, the Ministry of Health, and our patients and participants, and my collaborators at UAB. And I'd be happy to take any questions. Thank you for your time.
Thank you so much, Dr. Bolton. That was such a great overview of many different projects and issues that you and everybody at CIDES are dealing with. I am going to set aside all my questions because we have a number of questions from the audience. So let me get started. There are a couple of questions that are a bit similar, so I'll ask them at the same time. Somebody asks, do you think religion plays a role in sex being taboo to discuss? And related to sex, do parents prefer to educate their kids about sex, or are they accepting of school-based or community-based programs and effective teen-focused HIV prevention programs in Lusaka?
Great, thank you very much. And thank you to all of you participants for sitting through my whirlwind tour. And as I said to the team beforehand, this really was just, I wanted to give an insight into the issues that we're facing here, give you some idea of Zambia and Zambians and the adolescents we're working with. And so it's not purely research, but I really appreciate you sticking to the end. So thank you for your questions. Does religion play a role? Zambia is a very religious country. and most the population profess to being of Christian religion, and definitely that plays a role in the open and frank discussion around sex and sexuality. However, I do actually think that culture is far more important than religion, although the two are greatly intertwined in preventing parents from discussing this with their children. And I think that incorporating religion in some of our interventions has been necessary to improve acceptance and uptake, but I don't think it's the primary role. I think culture is much more important. And so the Ministry of General Education a couple of years ago, or maybe 3 years ago, actually passed a statutory instrument that said you had to have a sexual reproductive health program in the school. So regardless of what the parents thought, you had to have, there had to be some sort of SRH curriculum being shared. So the problem there is that not all SRH curricula are equal. And so what you're seeing is in many times the schools who are not supported by Grassroots Soccer, and I really believe Grassroots Soccer have an awesome SRH curriculum, the schools that do not have access to that, they are just using teachers who have counseling, be trained, who don't have counseling skills, and really just so that they can say this is done. So I have a right to refuse because by law their children have to have it in their schooling. But as I said, I think the quality thereof differs hugely. Having said that, and that's in public schools. In one of the private schools, which was a Catholic school, they would not allow Grassroots Soccer to come in and actually provide their curriculum. And so we tried to take it up with the Ministry of Education, and then COVID struck, so we backed off. But I think that that there still is this hesitancy, and there's this belief that, I'm sure you've heard it before, if we give them condoms, they're going to have sex, not realizing that if we don't give them condoms, they're going to have sex anyway, so we may as well give them the condoms, you know. And I think there's this mentality that talking about sex promotes sex, talking about condoms promotes condoms, and there's some good data that refute that, and we do share those data when given an opportunity. And the good thing is that, as I said, the Ministry of General Education is actually really supportive, and by law it has to happen. So at least we've got that. So if we were going to use the school-based curriculum, I think that will be fine. It's just trying to find the right people and modalities to deliver it. And given, as I said, the COVID situation, how practical is this? We've sort of started, then we'd stopped, and we started, we closed for 3 months, had to go back in. Our study is going to be quite a hybrid when we analyze the data, looking at how it was done. You know, some of them, the sessions were given close together, some of them were broken by COVID. There wasn't much we could do about that. But it might give us some real world data and some real world insight into the challenges if we were to use this modality going forward. I'm not sure if I answered the questions, but
yeah. No, that's great. One more quick question, because I know we are running out of time, but in several of your slides and the interventions that you're talking about rely on technology. And so somebody has asked, do most adolescents have access to smartphones? And I would add, would that be across Zambia in both rural, urban? You know, is it widespread enough to use technology as the primary mode of delivering interventions?
So I would hesitate to say the primary mode of delivering interventions, but I will say that most of the population within Lusaka and the Copper Belts have access to a smartphone. And I don't have those numbers in front of me. I don't have numbers for rural areas, but for Lusaka, it's something like 78% of the persons that we approached had access to a smartphone, and we were able to access different apps using the smartphone. So I think what we've seen really interestingly is that the vaccine hesitancy around COVID that we've seen here has largely been driven by Facebook and Twitter and TikTok. And so if they're able to use it for vaccine hesitancy and for spreading false information a lot of the time, we should be able to use it in the same way to spread correct information around whichever issues we choose to use. So I think we've seen a remarkable impact of social media amongst our adolescents particularly, but also amongst our older populations. And so I think the access and the influence is really remarkable. Shall we use it alone? No, definitely not. We try to use a Facebook based application to improve voluntary medical circumcision uptake in the rural provinces of the Western Province. I mean, in one of the rural areas in the Western Province, and uptake was really poor, or not uptake. The effect was really minimized. We weren't able to take it to scale. So I think we've learned that that's not going to work there. We have used WhatsApp successfully in rural areas, and I know in the US WhatsApp is not as commonly used, but in Zambia, almost every single person with a phone has WhatsApp and uses it to communicate for messages, photos, group calls, live locations, things like that. So really sharing information. So we found WhatsApp groups working really well, particularly with young boys, and we used it for voluntary medical male circumcision.
Great. Well, thank you so much. We do have some other questions that we didn't get to, but I know that you're very open to hearing from some of the people that participated, that were able to listen to you today. And I definitely think you've spurred a lot of thinking about what's happening in Zambia and what potentially could be done. So I just want to say thank you so much for your time. We really appreciate you putting together this presentation, and thank you to the participants for listening. This has been a really fascinating hour. So thanks, Dr. Bolton.
Wonderful. Thanks, everybody.
Okay.
And happy to take more questions. I don't know if they send them to you, but happy to engage.
Okay. Thank you.